So it is my pleasure to welcome Dr. Sarah Moore. Sarah received her PhD from Butler University and completed her postgraduate training in pharmacology and infectious diseases at Franciscan Health in Indianapolis. She works as a clinical pharmacy specialist in infectious diseases and antimicrobial stewardship at Norton Healthcare in Louisville, Kentucky, and her interests include multidisciplinary education, pharmacokinetics, and clinical outcome research. At this time, I will stop sharing my screen and welcome to Dr. Moore.
Thank you, Julia.
I will also add while Sarah is bringing her screen up, if you've not completed the pretest, we will put that link into the chat now.
All right. And Julia, are you seeing my slides okay before I get started here?
Yes, we can see your slides and we can hear you. Thank you
All
very
right.
much.
Well, fabulous. Then we won't hold off any further. We can go ahead and dive right into the material. So I'm going to be talking a little bit about multi-drug resistance today and how this plays out in therapeutics and the antimicrobial stewardship space, because of course, I know as a group of infection preventionists, our work is so intertwined with antimicrobial stewardship, and we're all working towards that common goal to address multi-drug resistant organisms and reduce those infections that we see moving forward. So as far as any disclosures, I do work with our statewide antimicrobial stewardship group, which is the Kentucky Antibiotic Stewardship Innovation Consortium, or KSIC for short, which is how we refer to it most commonly because that whole name is rather a mouthful. That, along with KYIP, has been supported by funding from CDC and the Kentucky Department for Public Health. As far as any financial interests, I don't have anything to disclose here, and no commercial support was provided for this particular educational activity. Now we can move on to talking about our objectives. So we're going to cover a lot of ground today, but again, the idea is kind of to focus on how multi-drug resistant organisms even come to be in the first place, what we can do about preventing them. And then because I've got a group with a strong nursing background, we also wanted to discuss some of these ways that nurses interplay with antimicrobial stewardship in addition to just infection preventionists. So our goals will be to define types of antimicrobial resistance, to discuss important multi-drug resistant organisms, including things like extended spectrum beta-lactamase or ESBL producing organisms, carbapenem resistant Enterobacterales or CRE, and then carbapenem resistant Acinetobacter species, also known as CRAB. We'll also determine MDRO rates from antibiogram data, define antibiotic de-escalation, describe how that de-escalation and discontinuation prevents the development of MDROs, and then last, like I said, discuss methods for nurses to support antimicrobial stewardship efforts. So when it comes to antimicrobial resistance, this is a term that gets thrown around a lot. And I think it seems relatively intuitive when we first start talking about it. However, resistance, like almost anything, when you look a little bit closer, is actually quite complicated. And there are a couple different ways that we may actually define it. So the first will be these two buckets, which is intrinsic and acquired resistance. So let's talk about what those both mean. Intrinsic antimicrobial resistance is when an antimicrobial medication's action is completely ineffective against a pathogen. Or we may say that that pathogen is outside the drug spectrum of activity. So a really clear-cut example of this would be fluconazole, which is an antifungal, will not treat a urinary tract infection due to E. coli, a bacteria. So that, again, is relatively intuitive. And when it comes to intrinsic resistance, there's really not much we can do about it. The drugs are made the way they're made to cover whatever pathogens they cover. And intrinsic resistance is just something that we have to live with. Now, on the other hand, we have something called acquired resistance. And this is where a pathogen has developed resistance to a medication that would typically be effective against it. So for an example, we have an E. coli that acquires a gene, which allows it to produce an enzyme that attacks and destroys beta-lactam antibiotics, this one being an ESBL. And acquired resistance is really what we're all talking about when we talk about preventing the rise of resistance. When we talk about things like MDROs, we're really oftentimes more concerned with acquired resistance than we are with intrinsic resistance. So this is where we actually have quite a bit more control with the decisions that we make when it comes to antibiotics to prevent this type of acquired resistance. Now, Another way we can talk about resistance is what's actually going on at a cellular level with the bacteria. And if we can understand these different ways that the bacteria actually become resistant, it can help us first think about what we may actually be able to use to treat them with, or B, come up with new mechanisms of action or new types of medications that may be able to treat these resistant bacteria. So if we can understand exactly what the bacteria are doing to inhibit that antibiotic, we may be able to figure out a way to get around it. So the first type of resistance we see is going to be a target site change. So what we can see here is that we're going to call this dark blue little blib our binding site for our antibiotic, which is going to be our lighter blue kind of pill-shaped thing here. And what the antibiotic is actually going to do is enter into the bacteria, go to its target site, and exhibit whatever killing action it has. However, if there's a change in that target site that changes the shape of it, and the antibiotic is no longer able to bind, then it's not going to be able to exhibit its mechanism of action, and it's not going to be able to kill the bacteria. So the analogy I like to use for this is it's like changing the locks in a door. Doesn't really matter that you had the old key. It's really not going to do anything for you. And this is what we would call a really high level of resistance. There's unfortunately just not a lot we can do to get around that particular type of resistance. The next thing we can talk about is porin channel alterations. So porins are these channels in the cell wall of a bacteria that the bacteria will use to bring in things like electrolytes, nutrients, whatever it really needs. And this is going to be a relatively passive process. It's kind of just, like I said, a little bit of a channel in that cell wall. However, it may actually be something that, again, our antibiotics use to move from the extracellular to the intracellular environment, and then eventually get to their binding site. However, if you get rid of some of those porins, it becomes harder for our antibiotic to actually get where it needs to go. And the analogy I like to use here is it's kind of like shutting down several lanes of the highway. Just going to be a lot harder to get where you're trying to go if some of those lanes are shut down. Next, we have something called an efflux pump, which is going to be another way that the bacterial cell will bring, again, electrolytes, nutrients, whatever it needs into the cell wall. But this is actually an active process. So the bacteria is using energy to actually run this pump. It is another way that we may have our antibiotics move from the extracellular to the intracellular environment. However, if the bacteria essentially wises up, it might notice that, hey, this isn't actually something I want in my intracellular environment, and can just go ahead and pump it back out. So the way I like to think about this is kind of like a revolving door in the cell wall that the antibiotic goes in and whoop, gets pumped right back out. So again, it's going to make it really difficult for us to actually get our antibiotic to wherever it's trying to bind. And then the last type of resistance, which is one we'll continue to talk about quite a bit throughout the presentation, is going to be enzymatic resistance. So enzymes are these little things that our bacteria will produce that actually can perform a lot of different mechanisms of metabolism, what have you, for the bacteria. It's part of what helps it actually do whatever it needs to do to continue growing, getting rid of waste, that type of stuff. But these enzymes may actually be developed that will go out and hydrolyze or destroy our antibiotic before they can ever get to its binding site. So again, this is going to be a adaptive type of resistance. Not all bacteria necessarily have enzymes specialized to get rid of antibiotics, but it's one of these things that the bacteria have developed over time that can really help them further survive, even in the face of being treated with antibiotics. So I know this is a ton of technical information, but I like to talk about this because, again, if we can understand what's actually happening at a cellular level, it helps us understand what type of treatment we may need in order to treat these resistant bacteria. So let's go ahead and move on to talking about those resistant bacteria themselves. So I know, again, we're talking to a group of people in the infection prevention space, so some of this terminology and information may be relatively familiar, but we'll go ahead and talk about it just because it is so important. So the first organism I wanted to discuss is our ESBL Enterobacterales, or extended spectrum beta-lactamase producing organisms. Now, on the right-hand side here, we have the threat estimate in 2020 from the CDC for each of these organisms. The CDC had done a report in 2019, and they did a follow-up report in 2020 with the idea of trying to track what was happening with resistance through the beginning of the COVID-19 pandemic. And unfortunately, it was mostly bad news. So we see with our ESBLs, there was an overall 10% increase in those infections, with a 32% increase in hospital onset infections. So despite all the infection prevention measures we had in place during the pandemic, we did still see an increase in the hospital onset infection space. This accounted for 97,500 cases and just over 9,000 deaths that year. The next organism I wanted to discuss is carbapenem-resistant Enterobacterales, or CRE. Thankfully, their overall rate in 2020 was stable, but again, we saw a significant hospital onset increase at 35%. We had closer to 13,000 cases and just over 1,000 deaths, so not quite as significant as what we saw with ESBLs, but certainly another organism that we're very concerned about because we have such limited treatment options. And then last, we have carbapenem-resistant Acinetobacter, better known as crab. Again, we saw an overall 35% increase in those infections, a whopping 78% increase in hospital onset infections, but again, actually quite a bit less frequent, so 7,500 cases and about 700 deaths. I talk about these in this order partially because when it comes to me thinking about which of these are most difficult to treat, we kind of move from ESBLs still being difficult, but not quite as difficult, to CRE and crab being really, really challenging when it comes to those actual treatment options. So even though CRE and crab may not have as many cases associated with them, they are such a bear to treat when any of them actually comes up that any amount of cases is still very, very concerning from a clinical standpoint. So let's talk about each of these and kind of bring it back to when we were talking about those mechanisms of resistance and fit that information together. So with our ESBLs, they're going to produce an enzyme that will hydrolyze and destroy the antibiotic before it reaches its target site. So we talked about that enzymatic resistance a couple of slides ago. That's what's actually going on with ESBLs. They're going to be resistant to penicillin and cephalosporin antibiotics, which tend to be two of our most commonly used types of antibiotics in the hospital. The good news is that many rapid diagnostic tests, like blood culture platforms, can detect the CTXM gene, which it most commonly encodes for ESBL resistance. I'll put the caveat on there that CTXM is not the only gene that can encode for ESBL resistance, but it certainly is around, or at least upwards of 90% of those. So it means that we can catch a lot of those infections earlier on and recognize that the therapy we're using may be ineffective. So this has really helped us out when it comes to both identifying these patients earlier so we can change therapy, as well as get them into isolation and ensure that we're not spreading that ESBL throughout our institution. The other part that I'll mention is that typically rates can be estimated based on ceftriaxone resistance on an antibiogram, and we'll talk a little bit more about that as we move through the presentation and what that can look like. This is what we'll actually see on a culture to help us recognize that this patient does in fact have an ESBL infection. Now again, ceftriaxone resistance tends to be the easiest way for us to very clearly identify this, but you'll notice some of our penicillin antibiotics, things like ampicillin, ampicillin sulbactam, those are all resistant. And then our other cephalosporins like cefazolin, cefepime, also resistant. The other thing I'll point out here is that even though we really only think about penicillins and cephalosporins as being the antibiotics that are affected by that ESBL enzyme, we will often see that unfortunately bacteria that have ESBL enzymes oftentimes have other mutations that confer resistance to other classes of antibiotics as well. So for example, ciprofloxacin, which is a fluoroquinolone, is also resistant. Sulfamethoxyl trimethoprim, also resistant. So this just helps demonstrate that even though, again, those ESBLs are going to knock out two of our major classes, they may also have other types of resistance alongside that, which can make them even more difficult to treat. Let's go ahead and talk a little bit more about CRE. They're going to produce an enzyme, again, that will hydrolyze and destroy the antibiotic before it reaches its target site. So very similar to what we saw with the ESBL, but this enzyme is even a little bit scarier. So it's going to be resistant to penicillin and cephalosporin antibiotics like we saw with the ESBL, but then we also have resistance to carbapenem antibiotics. So carbapenems were actually specifically invented and engineered at a drug company to try to overcome ESBL resistance. So they are thought of oftentimes as kind of being the drug of choice for ESBL infections. However, we see this kind of escalation of resistance. You use something else, and then you see resistance to that antibiotic. So that's how we got CRE. There are several different CRE genes that exist, and different therapies are needed depending on what type of CRE enzyme is actually present. So that's not something I'll get into the details of today, but knowing what type of genetic resistance is there can really help us on the therapeutic side to try to figure out what's the best treatment for that particular patient. So that may be testing that we do in the hospital to try to get a little bit more information about what kind of CRE is this. For your all's purposes, from like a isolation standpoint, that all doesn't really matter too much. A CRE should be managed the same way with isolation regardless. But when it comes to the therapeutic side, that can influence our decisions. So looking at an actual culture, we're going to see, again, resistance to those penicillins like ampicillin, ampicillin sulbactam, resistance to our cephalosporins, cefazolin, cefepime, ceftriaxone. And then really the calling card for our CRE is going to be resistance to a carbapenem antibiotic. So meropenem, we see it's also resistant here. And that's what's going to really tell us by looking at this culture, hey, we've in fact got a CRE on our hands. Last, but certainly not least, we have carbapenem-resistant Acinetobacter. What we have here tends to be actually multiple mechanisms of resistance. So not just an enzyme, but oftentimes we also have efflux pumps and porin loss. And that can, again, make it really difficult to actually figure out how to treat these patients. The calling card, again, is going to be carbapenem resistance. And oftentimes that resistance is going to come with resistance to other classes of antibiotics as well. So again, we see meropenem resistance on our culture, as well as levofloxacin resistance. So again, can just be very difficult for us to actually manage these patients from a therapeutic standpoint. And obviously, this is a pretty scary infection that we don't want them passing on to anybody else at our institutions. So I kind of alluded to this as we were talking about ESBL and CRE, but I wanted to reiterate this concept, is this idea as we escalate the spectrum of our antibiotics, we tend to see more and more increasing resistance. So let's say we have an infection that's pan-susceptible, which means we can use any antibiotic that we don't have intrinsic resistance to, so anything that shows up as susceptible in the culture to treat an infection. Let's say we just select something a little bit more broad because we think it's more convenient or it's better for whatever reason. It may be something that helps select out for ESBL resistance, and then we might treat with a carbapenem, and then we select out for carbapenem resistance, and that's how we get CREs. So this idea that we continue to use broader and broader spectrum antibiotics is how we end up with more and more resistant infections. So let's kind of look at this a slightly different way, just to really drive this point home. So we've got our patient here. They're going to be exposed to an antibiotic, and these are the bacteria causing their infection. Now, let's say that our blue bacteria are not particularly resistant, but we have this one red bacteria here that's just a little bit more resistant. And if we think about, back to like high school biology and Darwinism, we know that in a population of animals, of people, but as well as bacteria, there's some variability, there's some mutations. And this one just happens to be a little bit more resistant for whatever mutation it has, because all of those bacteria are not necessarily a monolith. Let's say we give our antibiotic, though, and it's a pretty broad spectrum one, and we kill off most of that bacterial population. We know that we live constantly with bacteria. the goal is not to sterilize all of our patients. The goal is to treat their infections, but there will be bacteria that grows back thereafter. And what can happen is now we've got this patient who's colonized with a more resistant subspecies because that's what's now making up the majority of the population. So the next time this patient comes back with an infection, it may be more resistant. And if they're out there living their life in the community, they're more likely to potentially pass on this more resistant bacteria to the people in their household or in the rest of their community. So this is how we can see that develop resistance in response to antibiotics. Now, we're going to shift gears a little bit and come back to this concept of resistance and all that, but let's talk about how that might show up in an antibiogram. Now, this is something that we utilize a lot on the clinical side, and it's going to be a summary of local antibiotic susceptibility and resistance trends. And it's a useful tool to making empiric antibiotic choices, which basically means when somebody gets to the hospital, and let's say they have a urinary tract infection, I'm going to look at whatever bacteria I think is most likely to cause a urinary tract infection, so in this case, E. coli, and look at what antibiotics have a high susceptibility rate and choose one of those to empirically treat my patients. So this is what this will actually look like. I'll just orient you quickly here. What we have is our organism over here on the far left, the number tested of that organism, which is typically going to be over a year-long time frame. And then the percent susceptibility for each antibiotic across the board. So for example, if we've got Staphylococcus aureus here, we tested 102 of those isolates. And let's see that 54% were oxacillin susceptible versus over here, 99% were vancomycin susceptible. So again, that just lets us know how likely we are to actually have picked an active antibiotic. Now, these are retrospective. They're not being updated in real time. Like I said, it's usually going to be over a year-long threshold, but they still can be useful tools to us, especially when it comes to estimating the overall burden of resistance at an institution. Now, I'll just make a plug quickly as well. Oftentimes, institutions do make their own antibiograms, but there may be some places that don't have access to that. If you are at an institution that doesn't have an antibiogram, we do actually have statewide antibiograms through CASIC, which are available on our website. So if this is not something that you have at your own institution and you're just looking for something to start from, that statewide antibiogram may be a good resource just to be aware of. All right, so let's go ahead and we're actually going to practice estimating an ESBL rate from the ceftriaxone resistance on our antibiogram. So go ahead, take a look, and if you can estimate what the ESBL rate is at this institution, I would love to see a couple answers in the chat once you think you've got it. All right, I'm seeing some answers roll in, so let's go ahead and walk through this one together. So looking here, we've got our E. coli, and then we're going to come over to ceftriaxone resistance, or excuse me, susceptibility. We see that's 89%. So what that means is we have about 11% resistance, which would say that we probably have about 11% of our E. coli at this institution are going to be ESBL. So let's go ahead, let's try another one. Let's look at Klebsiella pneumoniae this time and try to walk through that process. If you think you've got the answer, feel free to drop it in the chat as well. Okay, excellent. So I'm seeing a lot of the answer here in the chat, so great work, everybody. So with our Kleb pneumo, we've got 93% are susceptible, and that means that we've got about 7% resistant or likely ESBLs. So again, this is going to be an imperfect method. I know that oftentimes you all may be aware of patients in real time, case-by-case basis, that they do in fact have these resistant infections. But if you're ever asked to estimate, like how frequently are you seeing these, the antibiogram can be a nice way to help just estimate that. All right, so Now, moving on to truly what is my own bread and butter, which is antimicrobial stewardship. Again, this is a term I think that oftentimes we're all very familiar with. We know that we have antimicrobial stewardship programs that are working on antibiotic use at individual institutions. But I like to actually kind of take a step back and talk about what is like the real concept, the real goal of antimicrobial stewardship outside of really those operations at a hospital, long-term care facility, in a clinic. This is the definition I like, which is that antimicrobial stewardship is the optimal and responsible use of antimicrobials in every setting of society. So it's not just within healthcare organizations, but out there in our community pharmacies, and even broader than that, say on our farms and in our veterinary clinics and anywhere that antibiotics may actually be used. So it's not even just applying to human medicine. We're talking about antibiotics really across the board. And that really expansive definition, I think, is worth it to keep in mind because some of the time we all get siloed into our own ideas of what these things mean. I think oftentimes, especially in the hospital, sometimes people talk about this idea of the antibiotic police. And the idea it should really be a lot bigger than that. So this is a much, I think, higher calling than just, not using antibiotics when you shouldn't. We need to be thinking really, really expansively about what that looks like across all these different healthcare and non-healthcare settings. But what that might mean within our healthcare setting is what I like to talk about being the 5 rights. So this is going to be the right diagnosis, the right drug, the right dose, the right route, and the right duration. Now, if we get our diagnosis wrong, say this patient actually doesn't even have an infection in the first place, nothing else is going to be right, correct? And then it kind of goes from there. The right drug, hopefully we're going to utilize something that's appropriately narrow spectrum. The right dose, if we say underdose our antibiotic, even if it's the right drug, it may not work as well as we want it to. The right route is more really to make sure that the drug actually gets where it needs to go and ensure that we're not putting the patient at undue risk by giving like an unnecessary intravenous medication. And then the right duration, because we know that shorter durations tend to actually cause less resistance than longer durations. So we want to use the most appropriately short course as possible. Now, I touched on this idea of empiric therapy earlier, but let's talk a little bit more about that. This is going to be the antibiotic which is chosen for therapy with the initiation of treatment for any possible pathogen. So oftentimes this will be what we call broad spectrum therapy. However, as we get more information back about that patient, say we get culture results, or maybe we just learn a little bit more about their background and risk factors, we may be able to move to targeted therapy, which is an antibiotic selected based on identified pathogens or more narrow therapy. And this process is called de-escalation. So again, this is a term we actually hear, I think, quite a bit. But to talk about what it really means is to say oftentimes we go from covering a broad swath of bacteria to just a few. And let's talk about how that may actually influence this idea of selective pressure for resistance that we saw earlier. So again, here's our patient. They get their antibiotic. We've got our blue, less resistant bacteria, and our red, more resistant bacteria. We go ahead and kill off most of those blue bacteria. We allow for the red, more resistant subspecies to kind of take over. However, let's say we use narrow spectrum therapy. What we do is we kill off a lot less of that less resistant subspecies. So when we see that bacterial growth, we see that our more resistant bacteria actually doesn't take over. We allow for that less resistant species to still be the majority of the population. So hopefully the next time this patient comes back, we don't have to use more and more broad spectrum therapy to treat their resistant infection. All right, so that is all I have on all things resistance and antimicrobial stewardship and the interplay of those two things, which means that we can move on to talking a little bit about nurses and antimicrobial stewardship. Now, again, I know that a lot of you all probably come from a nursing background and probably know better than anyone all of the value that nurses provide across the board when it comes to healthcare. But I think a lot of times when we talk about antimicrobial stewardship, the focus is so much on providers and pharmacists, and we kind of forget oftentimes about nurses really being, I think, truly unsung heroes of a lot of antimicrobial stewardship work that goes on. There are things that they can do to help support that. And then there are also things that they're already doing that are so key to us performing good antimicrobial stewardship on a patient-by-patient basis. So I wanted to just take some time to talk about that in this presentation as well, and potentially give you some ideas to either bring back to your organization as far as things nurses can do in addition to what they're already doing, or really just to celebrate what your staff is already doing to take care of your patients and support these goals of antimicrobial stewardship. So the first thing we'll talk about is asymptomatic bacteriuria. Now, this may be a term that you're very familiar with or that you're not that familiar with, but we'll go ahead and talk about what it really means. So the Infectious Diseases Society of America puts out guidelines on what they call asymptomatic bacteria and how we should manage this disease state. Now, what is asymptomatic bacteria? It's essentially an abnormality where we have bacteria in a urinalysis, in the urine itself, but it's not necessarily actually causing an infection. So how can this manifest? We may see this on a urinalysis where it will flag as abnormal for bacteria or white blood cells, leukocyte esterase, nitrites, anything like that. However, that urinalysis alone, based on the Infectious Diseases Society of America guidelines, should not be used to diagnose a UTI. We actually still need some more information. We see something very similar when it comes to a urine culture. So this is where we may have growth of bacteria or yeast from that urine culture itself. But again, this alone should not be used to diagnose a urinary tract infection. What we really need to look at is symptoms. And we need to talk about these very specifically because we may have things like this first bullet, which are general symptoms: confusion, falls, foul smell to the urine or malodorous urine, a cloudy appearance. But IDSA tells us that these are actually not specific enough to diagnose a UTI. And when we think about these, particularly in like our elderly patients, they're really not very specific. Perhaps we've started a new medication that's causing confusion. Maybe they had a mechanical fall. Maybe they're just dehydrated, and that's why we're seeing that cloudy urine or having kind of an extra malodorous smell, or they ate something kind of funky. All of that is not specific in and of itself. What we do have are genitourinary symptoms, so things like dysuria, pain on urination, urgency, increased frequency, flank pain, which may be more indicative of pyelonephritis, or fever. So all of those things that are really specific to either infection itself or the actual manifestation of a urinary tract infection should be used to diagnose a UTI. So if we don't have those things or systemic signs of sepsis, anything like that, then the idea is that we should actually be asking the question to say, hey, is this diagnosis right for that patient? So coming back to those 5 rights that we talked about, the idea is to really say, like, is this the correct diagnosis before we even start treatment? So I wanted to touch briefly on a study that looked at involving nurses in trying to promote this idea of not treating asymptomatic bacteria in patients in Australia. So it's done across 17 nursing homes. And what they did is an educational program that asked their staff to self-reflect on urine dipstick testing. So kind of like we would do with urinalysis. And then did this education on best practices and a practice audit. They really, really emphasize this need for clinical assessment to determine the need to test. So talking about, does this patient have dysuria? Are they having increased frequency? Are they having flank pain? And really trying to utilize that to not just not treat them with antibiotics, but not even test them for a UTI if they actually maybe had some other things going on that needed to be investigated instead. So it was a qualitative before and after multi-site study. They conducted interviews with nurses and pharmacists who were really the people they focused a ton on educating in this scenario, and then reviewed urine dipstick orders at baseline, 3 months, and 6 months. What they found is that respondents reported increased prescribing appropriateness, so actually treating with antibiotics appropriately at 3 and 6 months. And they also noted that the key to success included nurse empowerment and patient education. So by educating their nurses about this practice and by empowering those nurses to go on and talk to the family members, that was really the foundation, I think, of being able to make these changes across this institution. You all very well may be familiar with this already, but there's a Gallup poll out there that talks about how nurses are one of the most trusted professions in our society. And that's not just in healthcare. That's just across the board. It's like nurses and firefighters are pretty much the people that are really, really trusted. And nurses tend to be, again, oftentimes taking that first spot across all professions, which really speaks to what a powerful force they can be when it comes to this idea of family education and getting people to buy into these concepts. So we'll go ahead and shift gears a little bit to talking about culture collection. And this, again, is something that's probably part of our everyday practice that we might not necessarily think of as being so critical for good antimicrobial stewardship, but surprise, it really is. So when it comes to culture collection, there are a couple things that nurses can do that are really, really important to actually supporting getting high quality cultures and allowing us to make good clinical decisions based on those. So the first is going to be timing. In an ideal world, we're going to collect our cultures prior to antibiotic exposure or antibiotic changes to increase the culture yield. And what that means simply is that we actually get something to grow in the culture rather than just seeing it come back negative. Antibiotic exposure obviously is going to kill off some of the bacteria that's growing. So if we can get that culture earlier, it's just more likely that we'll actually see something. Technique is also going to be important. So sterile collection technique increases the quality of that culture. So especially things like blood cultures, we worry a lot about contamination rates, and they can't really tell us nearly as much or can really kind of confuse the diagnosis if they end up being contaminated. So that's also very critical. But of course, the impact of those cultures is that it allows the treatment team to individualize therapy and make oftentimes those de-escalations from empiric to targeted therapy. So the downstream impact of that is, of course, that we may be able to prevent resistance by using those more narrow spectrum therapies when we've got those excellent cultures that are collected by our bedside nurses. Another one of the things that nurses are often doing on hospital admission that is very, very critical to supporting antimicrobial stewardship, going to be clarifying allergies. So again, it might not sound like it's something that we really think of as being a cornerstone of antimicrobial stewardship, but it truly, truly is. Again, they're often going to ask about those allergies on admission. And when the nursing staff is able to document details, like the specific reaction that the patient actually had, that's going to aid our treatment team in weighing the risk versus benefit of using a particular antibiotic. So for example, we may have somebody who describes that their throat closed up when they got an antibiotic. Okay, I'm not touching that with a 10-foot pole. That is somebody who we are just not going to try to use that antibiotic in. We may also have somebody who says, oh, well, my brother was allergic, so I've never had it, or I had some stomach upset. And those things we may assess a little bit differently and determine that it might actually be okay to consider using this antibiotic in this patient. So the more information we have, the better assessments we can actually make for that individual patient to really tailor their therapy. I want to talk a little bit about penicillin allergies specifically and the impact that this might actually have on clinical care. So this is going to be a patient with a population of patients with MSSA, methicillin susceptible Staphylococcus aureus infections. And they compared vancomycin to beta-lactams. Now, beta-lactams are the umbrella that penicillin antibiotics are under. And the reason you would probably use vancomycin, which is more broad spectrum, is likely because of a reported penicillin allergy. So we'll just get that out of the way. Now, this was a very large study, nearly 17,000 patients, and a retrospective cohort study across 122 VA hospitals in a 7-year period. And what they did is compared 30-day all-cause mortality. What they found was that the vancomycin group actually had higher mortality, and it was statistically significant. So I don't use this study as a scare tactic to talk about if you have a penicillin allergy, all those patients are going to die. That's not remotely true. But when we look at this as a large population level, the impact of those penicillin allergies does potentially change what happens to the patients with the long-term outcomes of their infections. So it really speaks to the importance of ensuring that we actually know what that reaction is, and we're only avoiding that therapy if we actually need to, versus just avoiding it again because maybe somebody had some upset stomach 10 years ago. That's a very, very different risk assessment from, say, my throat closed up. So next we have this idea of IV to oral transition or IV to PO. This is something that is oftentimes, at least at my institution, really supported by pharmacists, but it's something that nurses can really have a huge impact on as well because they get a ton of face time with the patient and are definitely most likely to see the provider on a daily basis as well. They are in the best position to holistically assess oral tolerance. So, how is that patient eating? How are they taking their medications? Your nurse is going to be the person who's got eyes on them the most and may be able to best assess, hey, they're doing just fine versus maybe they're struggling a little bit more to actually get those pills down. Nurses have the opportunity to prompt providers to just utilize oral therapy consistently. So what we oftentimes see when it comes to antibiotics is some of the time they'll be on lots of other oral medications and we just keep the antibiotic IV for whatever reason. So this kind of comes back to that 5 rights and the idea of the right route. You don't really want to leave a line in somebody unnecessarily because it can be a risk of infection. And ultimately, it's going to have similar clinical outcomes when we utilize oral antibiotics and hopefully decrease nursing burden. So I bring this up because there was actually a study that came out a couple years ago that looked at the IV administration time and found that it took about 22 minutes to administer an IV medication on average. Versus with an oral medication, it's going to be only 5.5 minutes. So that's to, go grab it out of the Pyxis or a delivery box, get it to the actual patient is going to be a much shorter process for our nursing staff. So when we think about that as, again, the impact across many patients that your nurse may be caring for, that's going to give them a lot of time back to hopefully continue to provide really, really great care. So last but not least, we do have the opportunity for nurses to also prompt that de-escalation process. What we have often is that nurses may be aware that cultures have resulted prior to the provider noting it in the chart. Again, our nurses are, I would say, the most attuned to what's going on with the patient on a minute-by-minute basis. And what they can do for the provider is say, are we able to de-escalate antibiotics now that the cultures are back? I don't really expect my bedside nurses to talk through, the risk-benefit of each individual treatment option or be really, really tuned into what's the most narrow therapy necessarily. But again, once we've got that information back, simply asking this question may prompt the provider to actually go ahead and assess it and make a decision sooner. I think the impact of this is just we have another care team member advocating for antibiotic de-escalation. And the more that we normalize that this is a really critical part of taking care of all of our patients, the more likely it is to happen on a consistent basis at our institutions. All right, so here are my references, and I will go ahead and open up the floor for any questions at this time. You're welcome to either come off mute or drop stuff in the chat, whatever's easiest for you.
Any questions for Dr. Moore? We have opened up chat, and then you can also put questions in the Q&A. Or raise your hand. It looks like there are some people. Benjamin Howard, your hand is raised. I don't know if did you have a question or, okay. I do see a comment. Thank you for going over the antibiogram. Have a much better understanding of this now. Yes, they can be confusing. I think, and it is helpful to really understand what those are. Can you go back over? Okay, so there's a person that asked, can you go back over the antibiogram and how to get to those numbers?
Sure, absolutely. Let's go back here. All right, so let's go ahead, since I've got this one pulled up here, we'll talk about ESBL, Klebsiella pneumoniae rates. So if you'll recall, I remember from earlier, we talked about ceftriaxone is going to be our rough estimate of our ESBL rate. So that's the drug we're looking at here. And here's Klebsiella pneumoniae, our organism. What we see here, this 93%, is the percent susceptible of those organisms. So 93% of our Klebsiella pneumoniae are susceptible to ceftriaxone, which means The inverse of that, 7% of those isolates are resistant. So that's going to give us a rough estimation of our ESBL rate being about 7% of those isolates. Now, if you wanted to, you could also take that 7%, multiply it by 80 to get the rough number of cases of ESBL in a year. But again, that 7% is kind of what we're looking at here. Great question. So I see another question in the chat that says, what is the current thought or discussion on reducing the time frame of antibiotics, 5 to 7 days versus 10? Fabulous question. We definitely touched on this idea of right duration. So I'm glad to certainly talk about that a little bit more. Now, what exactly is the right duration is going to depend a little bit on what infection we actually have and how severe it is. If we have something that's more severe, or say our patient is maybe just a little bit more medically frail, they just take a little bit longer for their fever to actually come down, something like that. Those are things that might push our durations a little bit longer. But what we're finding is when we actually go in and start doing studies with shorter durations of therapy, we see that oftentimes patients do just as well. So, for example, there was a big trial that just came out in the fall called the BALANCE trial, and it looked at patients with bacteremia. They left out a couple different organisms. So things like Staph aureus were not included in that study, but it was like a lot of E. coli, a lot of Klebsiella, a lot of Enterococcus species, and they included those patients who were critically ill and those who weren't. And they compared a group that got 7 days of therapy versus 14 days of therapy. And this was a large prospective randomized trial, really, really well designed. And they found that those patients who got that shorter course at 7 days did just as well as 14. So this is one that's probably going to be a big landmark trial in the realm of infectious disease, that even when those patients had these severe infections, had bacteremia, we still can utilize shorter courses of therapy in many scenarios. Again, there's always got to be looking at the specific patient in front of you, but our defaults probably should be shorter than they traditionally have been. I also bring up this as an example. It's going to be really dated and is certainly before even I was born. But if I bring it up just to talk about how we do really change practice significantly over time, and even though it might feel kind of uncomfortable to us, we should recognize where we're coming from. So back in the 1980s, the standard of care for pyelonephritis was 6 weeks of antibiotics. And they did a big study at the time, found out 2 weeks did just as well. And now that's about the longest possible course we use for pyelonephritis is 14 days in the modern era. But again, that sounded really, really crazy in the 80s. We used these really long courses. So just to recognize that this is something that we're constantly refining our understanding of. And it will continue to change probably through all of our careers. But yes, overall, we're seeing that shorter durations are probably going to be where we're going moving forward to help prevent this rise of resistance.
I see another question here. It says, often in nursing homes, we send residents to the ER with something unrelated to an infection, and they come back with UTIs, pneumonias, etc. because of the quote fishing expedition. It is often difficult to get all labs and cultures back. What are your recommendations for this issue?
That is a great question. And I think that there are probably a couple things that I can recommend. The first is going to be giving the ER physicians as much specific information as possible when you're sending your patient over will hopefully prevent perhaps some of that, as you rightfully called it, like fishing expedition. If they know what you were concerned about and the more specific that you're able to be, probably the less likely they are to go looking for something that's maybe perhaps not even really there. As far as getting those cultures back, oftentimes, at least I know like our practice should be to include it in the discharge summary information. But if that's not there, you are always welcome to call either the ER itself or like medical records, or even potentially the lab. That's one of the things that I will utilize is just calling another hospital and saying like, hey, can I talk to your lab staff to get some of that culture information? Again, it's going to be a little bit imperfect, and it obviously I know is like an administrative burden on whoever's trying to actually get that information. But that's one of the ways that I've at least done that for my own patients when they come from other institutions. And I know there's a culture floating around that I'm just trying to get an actual assessment of.
All right. Well, thank you very much for a great presentation.